Uh, Thank you, Dr. Devdulal, for putting me into this, star-studded session, which is all the previous surgeries was excellent in by default, and I will be sharing. I think this is most of you have already seen this. Is it visible now?
Yes, yes.
Yeah. So I will be. So this is one of the most important. Treating macular hole is a day-to-day practice for a vitreoretinal surgeon. So you can once you do a normal macular hole surgery. So this is just a routine step for all standard macular hole surgeries. This is ILM peeling of a large ILM peeling, but even after do also you can land up of having the macular hole is open. So once you have a large macular hole or an extra large macular hole, so you always initially itself to prevent this kind of inverse flap technique, which is most well adopted technique. I'll be more focusing when we have a very large macular hole which cannot be covered by this. So in that situation, we can just take a free flap of ILM and then plug into it. So there are other way of handling it. The lens capsule or the amniotic membrane has also been tried in this kind of extra large or non closed holes. But then we had an idea that why not to put because all of them are actually a scar tissue. Then to see why not to put the retinal tissue there per se as such, and see how this graft is functioning. So, but as you know that retina is a continuation of the brain tissue, and the neural tissue cannot be grafted as of now. So we thought, let us try, and then we have designed a trephine and then taken a predetermined size of the trephine, which is slightly more, is 15% more than the hole size, which is a failed macular hole. This case is a failed macular hole surgery, and then you can very well see this graft, and then and it is almost unedited portion. So the grafting, the trephining portion has been done under saline, and this placement of the graft has been done under air, and this is gently tucked by silicone tip, and the whole macula, the residual fluid is taken up by a silicone tip fluid needle, and this is the donor site is now being lasered, and this is followed by fluid gas exchange. Fluid gas, I mean the exchange with this C3F8 gas. So with this procedure, then we were waiting for this result, and then we were very much thrilled to see that hole is completely closed, and you have a somehow kind of a graft tissue which is lying there, which has a little bit more similar to the retinal architecture rather than the retinal scar which I have shown you earlier. Now, if you see, this is the functional, this is the anatomical success. But what is the the functional the ability of that graft, whether it is able to perform or not? So for that we started performing central 10-2, and you can see it here of the same patient. You have our central 10-2 is 25 to 27 decibel of macular threshold, so which is significantly higher. And these are the this is the old record of our only initial 7 cases, and this has been started since 2014 was the first graft was done, and this is the initial 7 cases, which has a near about 3 out of 7 cases has a significant improvement of vision, especially the near vision, and the patient was able to read newspaper with that eye. So this is one of the most important part of it. Now, the most striking difference, this kind of retinal grafting has already been tried by different surgeons all over the world very recently, but again the technique which is lying different is there. Here it is the graft which is lying over the macular hole. not actually fitting into the size. But in our cases, we are just taking them of the exact size of the macular hole and then putting into the hole, assuming and hypothesizing that there is, once you have the neural tissue in contact, they can have a aberrant rejuvenation between those two raw surface, and the transmission can happen. So that is probably the hypothesis behind it. And due to this, the significant amount of the macular function has been restored. This is a normal case. This is a normal macula foveal multifocal ERG. This is a case when we did ILM peeling, standard ILM peeling, and this is a case when in case of failed graft, we have given this MFERG, but this is the retinal graft tissue. You can see all of them in one page, and you can see the difference between the functional ability of the graft. Now, this is actually, as Dr. Devdulal was telling, this is actually not the end of your road. So once you fail, then you start thinking of how to overcome it. And probably there are a lot of cases are needed to support this hypothesis. But again, we have done almost near about 15 cases as of now, and with a successful outcome. So these are the 3 cases, initial few cases, which I'm showing it here, and probably this is the way forward. And we need to have a much more of this kind of cases doing together. The similar way we can do it for the larger size of the hole. The size you determine and then refine it accordingly, and then put the graph there. Thank you all.